Olivier Daugemont is my name. I'm head of vascular access of the kidney transplant program. It's been a pleasure preparing this with you. Caroline Berthold, she's an intern. She's been here with us since April, and I'm looking forward to the final version.
Thank you for the introduction. Good morning and welcome to my presentation on central venous access. Today I would like to talk about three things. Firstly, we're going to talk about the indication for central venous catheters. Secondly, we're going to talk about the different types of catheters and their advantages and disadvantages. And then thirdly, we're going to talk about the surgical complications and how to deal with them. Let me give you a short overview of all the different accesses that we have at hand. There's arterial access, venous access, intrathecal access, peritoneal access, and intraosseous access for administering drugs of volume if necessary. Today we're going to focus on venous access, which can be subdivided in peripheral venous catheters and peripherally inserted central catheters and centrally inserted central catheters. There's three subtypes, and I'm going to talk about these in a minute. First, let's remember on what the definition of central access is. Central means that the tip of the device is located in the superior vena cava, the right atrium, or the inferior vena cava. Now, the types of central venous access, non-tunneled catheters are placed subcutaneously, and the catheter links the venous cannulation site closely to the skin exit site. These catheters should only be used for temporary access due to increased risk for infection. And if you use these for long-term access, you should only use them with a valve mechanism which will prevent blood flow or the backflow of blood and therefore prevents thrombosis or infection. Tunneled catheters transverse a subcutaneous tunnel from the venous cannulation site to the skin site, and these catheters are often used for when the risk for infection is increased. They come with a cuff which keeps them anchored in place or also limits the entry of bacteria, and this is probably one of the reasons why these catheters are less often linked to infection. Totally implanted devices or ports are the ones where the catheter links the venous cannulation site with the port which is located in a pouch. The pouch is most commonly situated in the chest of an adult patient, but it may also be located in the upper extremity, the abdominal wall, or even the lower extremity if necessary. Let's have a quick look at the history of these fantastic devices. Forsman was the first person, a surgical resident in Germany, who cannulated his own antecubital vein and introduced a catheter going straight to his heart. He was the first person to document this, and due to this being an authorized experimentation, which he also applied on patients, he was later fired from his position. Cunard and Dickinson fortunately developed these devices and refined them, and then in 1956, the three of them received the Nobel Prize in Medicine for their achievements in catheters. In 1968, the first jugular access lines were introduced. They were mostly made of polyethylene, which was a fairly stiff and brittle material. It was also then that the first Seldinger techniques were applied. In 1970, Broviak and Hickman started using silicone catheters, which are a lot softer and therefore also can be used for tunneled catheters, which is more difficult depending on the angles that you would introduce them. That's why they have to be softer. In 1982, portacath, the first portacath was used in clinic, and also ultrasound-guided access started coming up. Nowadays, we mostly use caths which are made of polyurethane, which is a material, depending on the manufacturing process, is fairly soft or fairly hard, which makes it the perfect material for all kinds of catheters. Now we're coming to take-home message number one, which are indications for central venous accesses. Anyone?
Delivering venotoxic medication or parenteral nutrition.
Mm-hmm.
Long-term antibiotics.
Very good. Yeah, there's lots. There's chemotherapy, vasoactive drugs, hyperosmolar solutions, parenteral nutrition, as you already said, stem cell transplant, and there's also frequent blood draws, which I would consider only a benefit resulting from a central access and not necessarily an indication. Let's have a look at the contraindications. Skin lesions at the insertion site, history of venous thrombosis at the insertion site, and when I was preparing this topic, I kept coming across this coagulation disorders, if there's a contraindication or not. Now, I found this study which was published in Transfusion by Van der Weert. They had a look at 13,256 catheter insertions. About 4,000 of them had severe coagulopathy, and 3,000 of them were uncorrected. The bleeding incidence in those suffering from severe coagulopathy, and which was uncorrected, was 0 to 32%. And however, the severity did not predict the risk of bleeding. There was no benefit from prophylactic administration of platelets or fresh frozen plasma. And then retrospective observational studies said that the INR below 3 and platelets above 20,000 was safe to administer a central venous access. At our department, we would say the same. We would give a central venous access, but tell the patient that we would not use the Saldinger technique and only go for venotomy. How do we choose the catheter? Once we know about the indication, we have to look at how long is the catheter supposed to stay in place, how many lumens do we need, what is the coating of the catheter, patient-related factors such as post-mastectomy or handedness, and what is the nature of the solution that should be applied. Now let's have a look at the different devices. Portacavs can stay in place for up to 5 years if they're taken care of. They're totally implanted devices, which makes them more safe against infection, and also for cosmetic reasons, sometimes these devices are preferred. They can be punctured up to 2,000 times, and please consider when you would like to give the patient a lot of volume at a time, and the needle is the limiting factor because it is smaller than the catheter, and therefore it is not the optimal device to administer volume. The devices nowadays are all MRI compatible, and an advantage of these devices is that you can administer a vancomycin lock for prophylaxis of infection, which is especially important in patients undergoing chemotherapy or immunosuppressed patients. Specific complications are pneumothorax, the Pinch-Off syndrome. That's why I should always consider the handedness of the patient. Centrally inserted central catheters can stay in place for weeks to months. They're usually applied at the subclavian, the jugular, or the femoral vein. And specific complications are caused depending on the site, pneumothorax, hematothorax, lesions of the neck vessels, and irritation of the plexus. Peripherally inserted central catheters can technically remain in place for 5 to 6 months, but in daily practice we see that they often start thrombosing or occluding within the first 3 months. Specific contraindications for these are status post-mastectomy with lymph node dissection, and also chronic kidney failure, because you wouldn't want to touch these veins with regard to future hemodialysis. Breivik and Hickman are the catheters I told you about before. They can stay in place for months to years. They're tunnel catheters. Today, they are used as synonymously, but basically one is a lot larger. The Hickman catheter has a bigger lumen, and therefore they have different indications. The Breivik is the one preferably used for parenteral nutrition. They're made of silicone, and we're at take-home message 2. The choice of the catheter is the short term. If you're looking for a device which should stay in place for a maximum 14 days, you should go for a non-tunnel centrally inserted catheter. Weeks to months, go for a tunnel PICC, and for long-term administration, you should go for a port for the reasons mentioned before. If you're looking for the administration of parenteral nutrition, this is your main concern. For short-term, go for a PICC. For long-term, go for a Breivik catheter. This can stay in place for years. We know about patients at the hospital here who have that. So now that we've decided that the patient needs a catheter and that we said we're going to go for a port, we're going to have a look at the different surgical techniques. The first one I'm going to talk about is the venotomy. We prepare the sulcus, we perform the venotomy, then the catheter is inserted, we prepare the subcutaneous pouch, the port is then connected and fixed to the catheter, and then it is fixed into the pouch, and then we do an intraoperative X-ray. The venopuncture or Saldinger technique, with this one you would puncture the vein, introduce the Saldinger wire, dilate the insertion site, and then introduce the catheter. Now, I've talked to a couple of people in this department, and they all said that we more often use the venotomy as a technique of choice. I found a study of our department, which was published in 2009, which randomized 152 patients with a primary endpoint of primary success rate of insertion of the catheter. Secondary endpoint was the overall success rate, procedure time, and perioperative complication rate. Now, the study found that the primary success rate was higher in Saldinger technique, and the time of operation was shorter for the Saldinger technique. Perioperative complications were about the same for both. Now, the question is, why do we still perform a venotomy more often than Saldinger technique? There is 3 very good reasons. Firstly, the risk for pneumothorax is minimized in venotomy, which then leads to the fact that we do not need post-operative x-rays. And thirdly, it is also a great teaching opportunity. Now let's have a look at the complications of the fact when we administer these central accesses. Pneumothorax, infection, hematothorax, Pinch-Off syndrome, kinking, thrombosis, bleeding, and hematoma. Of course, all of these depend on the access site and the device we're using. Let's have a look at the pneumothorax. What are symptoms of a pneumothorax?
Dyspnea, pain.
Anything else? Sometimes the patient might be coughing. Patients who suffer from pneumothorax, they will need, depending on the size of the pneumothorax, they will need treatment. Now, can you tell me above which size we would go for treatment of a pneumothorax? Does anyone know?
Second intercostal space, mid-clavicular line, with a wide bore cannula. If
that
you're
would be the
worried
treatment.
about a tension pneumothorax.
Let's just stay with the normal pneumothorax for now. Basically, the patient needs treatment once he is symptomatic, or if the pneumothorax is bigger than 2 to 3 centimeters at the level of the hilum. That's the European standard we're using. Thank you. Let's have a look at the therapy. If a patient suffers from pneumothorax, symptomatic, or the pneumothorax is fairly big, you would go looking for the safe triangle, which is located or limited with the pectoral muscle, the latissimus dorsi, the 5th intercostal space, and the axilla. After having administered local anesthetic, you would then prepare the 4th intercostal space and introduce your bullous drainage. I know there's different ones, but we're only looking at this one today. Don't poke it into the lung and stick to the thoracic wall. With the Seldinger technique coming up more and more, and also the ultrasound-guided administration or placement of these catheters, we have to ask ourselves, would it be more reasonable to use ultrasound as a diagnostic tool for diagnosing pneumothorax? I found this study by Ding, which was published in 2011, a meta-analysis of 20 studies, which had a look at the sensitivity and specificity of ultrasound and X-ray for the detection of pneumothorax. Now it found that the sensitivity for ultrasound is at 88%, whereas with chest radiography it is only at 52%, and the specificity is about 100% for both. Why should we keep doing X-rays instead of ultrasound? There are 3 very good reasons. Firstly, the bigger the pneumothorax, the higher the sensitivity will be, and the smaller the pneumothorax, the less consequence it will have for the patient. Secondly, ultrasound diagnostics need a very experienced clinician to perform these. So just to say sensitivity was better in ultrasound is not really a good reference. Thirdly, with ultrasound, you cannot evaluate the size of a pneumothorax. So basically, you won't know whether you have to do therapy or not. If you only know there is a pneumothorax, you'll still have to do further diagnostics. Okay, and please remember that auscultation is one of the most important and most specific tools in diagnosing a pneumothorax. Now let's have a look at infection, another complication of central venous accesses. The definition is laboratory-confirmed bloodstream infection not related to an infection at another site that develops within 48 hours of central line placement. The cause number 1 is lack of hygiene. The germs which cause these are coagulase negative staphylococci, Staph aureus, and the 2 others mentioned. Treatment will be, depending on the indication for the device, explantation or antibiotic treatment for as long as possible. Prophylaxis can be administered with vancomycin, applying this antibiotic clock, as I mentioned before. Now I'd like to show you 2 cases which suffered from complications of central venous access. So there's this one. You can see that there is a perm cath going right down the vena cava to the liver veins, and this catheter was dislocated, which led to a Budd-Chiari syndrome of the patient, and he suffered severe consequences from this dislocation. So please, when you decide to give a patient a central access, think about what can happen and be sure about your indication. Here, this is the coronary view. You can see that it goes right down to the veins. And then this patient had a central venous access at the jugular site. 8 days later, he started suffering from pain, and there was also swelling with no signs of infection. and he had to be taken to the theatre to evacuate the hematoma. So we have seen the indications for catheters, the choice of catheters, and also the treatment of a surgical complication. I would like to thank you for your support when preparing this presentation, and I would like to thank you for your attention.
Yeah, thank you very much. Very good, important presentation, since this is a common procedures that we are doing, and like any other center, there are complications. I think well presented, didactically very well done. Maybe a question for Dr. de Rougemont about, this is a frequent procedures. We do that very often here. I think it's clear the indication need to be clear. What the minimal requirement to do it? How do you train people? Should everyone be able to do a porta-cat? Should we have some sort of special, we have a special team, you're in charge of this. How many of those need to be done that the people can do safely? We have major complication. Arterial bleeding is one of the major complications which can even result in death in some cases with, of course, big consequences because nobody's expecting this kind of complication. So maybe tell us about the teaching of this procedure and when are the people ready to do it by themselves?
Well, thank you very much. It's an important question, and I probably don't have the answer for it in numbers. It depends on I think it's an important procedure, so you need to take your time and put a little bit of love in it. If you're doing it, it's just not putting in a catheter. It's just an operation like every other operation. Speaking of numbers, how many do you need? I think if you, as a surgeon, if you have enough other procedures, if you do this with someone who does it frequently 2 or 3 times, I think you can learn it by yourself. That shouldn't be a problem. And like for every procedure, if you have a problem, call early. And then it can be that the complications won't. We don't see many complications anymore. The last pneumothorax was about 4 years ago, so you don't see many complications. Just take your time and call early if you have problems.
Well, sometimes you may even have some piece of the catheter moving away. We have a case not a long time ago, which ended up to be resolved. But many of these complications can certainly happen related to that, and the bleeding is the most dangerous. So here, this is also, you have a team. Usually, is a technical team who does it, but the indication comes from many places. And that's always a bit the risk that there is a discrepancy between the indication and the one who do the procedure. How do you secure that the indication is correct?
Well, first of all, you just have to question it every single time you look at it. But, I mean, there's not many indications which are wrong for the catheter, to be honest with you. So we do not put the central venous lines. These are put by anesthesia. Probably there, the indication is not always very good. But for the totally implanted and for the long-term catheter, I think the indications are well thought.
Can you do this procedure in the room of the patient? The centers, you don't move the patient, you go to the patient, or should we go to a specific place and ready in case of complication, like a shock room or something, or the OR?
Well, we talked about this a couple of years ago. I think you can do it everywhere and be some kind of a hero for your patient. Put this in any room. I don't think it's wise because first you won't have the hygiene. Second, you need to monitor to put it in. You need your ultrasound. You need to be comfortable doing this procedure, and I don't see why you should do it in the patient's room. I mean, if it works well, everybody's fine with it, but it's a procedure you do frequently, so you will have frequent complications.
You mentioned that the porta-cat is not a line to give a lot of volume. Isn't it true that all these central lines are not really volume lines? Because I just learned that when we were with a patient in the shock room who had a ZVK, that this is not a good option to give a lot of volume, that he also needed a volume line because with the ZVK you couldn't give him the volume he needed.
I think that is correct. I was just using the porta-cat as an illustration because I think with this you can visualize it best when you see the needle really being the thin needle and then the catheter being a lot bigger, but I think we'll remember from emergency medicine classes, it always says zwei periphere Granulen.
Well, it just depends on the diameter of your line. I mean, if you have a perm cat, you can take a whole lot of volume. You can put in 200-300 milliliters a minute. So it just depends on the diameter. And the diameter of the needle, of the portacat needle, is small. Of a 3-lined central inserted catheter, it's small too. So the peripheral will be bigger. It's just about the diameter.
Okay, well, thank you very much.
Thank you.